A cyst is an epithelium lining sac containing fluid or semi-solid material. In the formation of a cyst, epithelial cells first proliferate and later undergo degeneration and liquefaction. And if the liquefied material exerts equal pressure on the walls of the cyst for moving, this makes the cyst spherical, except when adjoining teeth produce unequal resistance to this growth. This grows by expansion and do displace the adjacent teeth by pressure. When large, they can produce expansion of the cortical bone. Origin. Odontogenic cysts are those which arise from the epithelium associated with the development of teeth. The source of epithelium is from the enamel organ, the reduced enamel epithelium, the cell rest of molluscs, and the remnants of the dental lamina. Cysts are formed either in the bone or in soft tissue. When formed in bone, they are called central cysts, and when formed in soft tissue, they are called peripheral cysts. Clinical features of jaw cysts, often known as all, swelling, usually bony, smooth, but later soft, bluish, and fluctuant. Displacement of teeth, increased mobility of teeth, evidence of a fault, missing or non-vital teeth, infection, and rarely pathological fractures. Aspiration of contents of cystic sac. In addition to the clinical and radiographic examination, aspiration of the contents of the cystic sac may be a valuable diagnostic aid. In cysts whose size is larger than 1,5 to 2 cm thin, or thick fluid may be aspirated, which precludes the presence of the other more solid lesion. Radiological features and technical aspects. Occlusal view, OPG, PA lateral oblique, CT for bony lesions, or MRI for soft tissue lesions. Radiological features, a well-defined radioresensor with a corticated margin. Uniocular or multiocular relation with teeth. Reticular, dentigerous relationship, dentigerosis and keratocyst. Capable of displacing or resolving teeth. Relationship with adjacent structures, usually displace inferior alveolar canal, and extends into and displace maxillary antrum. Radiological signs similar to those of the other lesions, ameloblastoma. Differential diagnosis of radiolucencies of the jaw. Cyst, well-defined, corticated, locular or multilocular, displacement of the adjacent structures. Central giant cell granuloma, well-defined bone jewelry, not corticated. Ameloblastoma, multilocular, uniocular, defined or diffuse edge, usually displace adjacent structures, may resolve roots of adjacent teeth. Ossifying fibroma, diffuse edge, mixed radiolucency, and O positive. Myxoma, so bubble. And multiple myeloma, multiple punched out, rounded but not complicated. Classifications of the cysts, Robinson's classifications. It is old. Okay, and the newest classification, Buchau classification, divides cysts of the jaws for epithelial development, odontogenic, gingival cysts of infants, odontogenic keratocyst, dentigerous and follicular cyst, eruption cyst, lateral periodontal cyst, gingival cyst of the adult, hypotrigoid odontogenic cyst, glandular odontogenic, shallow-odontogenic, mucoepidermoid odontogenic cyst, and calcifying odontogenic. Non-odontogenic, nasopalatine duct, incisive canal cyst, nasolabial, nasoalveolar cyst, mid-palatine Raphael cyst of infants, median palatine, median alveolar and median mandibular cyst, globulomaxillary cyst, inflammatory, radical cyst, apical and lateral, residual cyst, paradental, mandibular infected buccal cyst, and inflammatory collateral cyst. Non-epithelial, solitary, traumatic simple hemorrhagic bone cyst, and aneurysmal bone cyst. Cyst associated with the maxillary antrum, benign mucoidal cyst of the maxillary antrum, and post-operative maxillary cyst. And the third cyst of the soft tissues of the mouth, face, and neck. Dermoid and epidermoid cyst, lymphoepithelial cyst, pteroglossal duct cyst, anterior median lingual cyst, oral cyst with gastric intestinal epithelium, cystic fibroma, nasopharyngeal cyst, thymic cyst, cyst of the salivary glands, mucous extravasation cyst, mucous retention cyst, granula, and polycystic degenerative disease of parotid. And J, paracystic cyst, related cyst, cellulose, and trichinosis. Odontogenic cyst, primordial cyst, dentigerous, radicular, lateral periodontal cyst, residual cyst, odontogenic keratocyst, and calcifying odontogenic cyst. Radicular cyst, periodontal, dental, periapical cyst, inflammatory, and infectious cyst. The most common cyst is frequently classified as an inflammatory cyst, origins from the tail rest of masses which are present in periodontal and periapical ligament and in periapical granulomas. The main cause of the cyst is infection from the crown of a carious tooth, producing an inflammatory reaction at the tooth apex and forming a granuloma. The like affection of the apical granuloma produced a radicular cyst. The part of the involved tooth is degenerated and the tooth is non-vital. Radicular cyst in a multi-rooted tooth where only one root is associated with the pulp or pericarpatosis, the tooth will frequently give a vital reaction. Initially, the patient may have had pain from the pulpitis, and this is followed by a period without symptoms when the cyst is formed. Painless, but may sometimes exhibit mild pain or sensitivity to percussion. Radiographically, the radiolucency is well circumscribed at the apex of the tooth and usually has a radiofractal border. The lamina dura and periodontal ligament space are destroyed in the region where the lesion is attached to the root, although a radicular cyst may be misdiagnosed for a granuloma or an abscess. The specific diagnosis is not that critical because all three can be treated by endodontic therapy or with curettage and apicectomy. You can see on the picture here and here, and here, and maybe also this location. Big cyst. You have big in this space. Yes. And you can see on the picture how the excochleated cyst. And augmentation of the bone. Consider. And the second case, here we have the cyst. And extract the two and excochleated cyst. Augmentation. And good therapy. Here we have two giant cysts. Lateral periodontal cyst. The lateral periodontal cyst develops in the periodontal ligament adjacent to the lateral surface of the root of an earth tooth. This is uncommon cyst, and when found, is often located in the mandibular premolar region, which is an area where supernumerary teeth are frequently found. The lateral periodontal cyst is an asymptomatic cyst, and the involved teeth are vital, unlike a radicular cyst. A radiograph, the cyst is seen as well-defined round or ovoid radiolucency with a radiopart border. Centigrove cyst is also named like a follicular cyst. It is formed from the accumulation of fluid between the reduced enamel epithelium and the completely formed tooth crown, or in the layers of the reduced enamel epithelium. The crown projects into the cystic space. The tooth remains unreerupted because of the overlying cyst. Almost exclusively occurs in the permanent dentition, especially in association with impacted mandibular molars and impacted maxillary canines. Sometimes the cyst may be situated only one surface of the crown. It's found in children and adolescents. The high incidence is the second and third decades. Radiopically, the well-defined radiolucency has the radiopart border and surrounds the crowns of an impacted or unwrapped tooth. The differential diagnosis of pericoronal radiolucency includes dentigrowth cyst, mural ameloblastoma, odontogenic adenomatoid tumor, odontogenic keratocyst, ameloblastic fibroma, ameloblastoma, and calcifying odontogenic cyst. Here we have a big dentigrowth cyst in this location, and here we have mixed only pathological results. We can say Is it the dendrils or also periapical? Residual cyst. When a tooth having a radicular cyst at its apex is extracted, the radicular cyst is left behind in bone, and it is now called a residual cyst. Can also arise from remnants of the epithelial rest after the extraction of a tooth. Occurs in older individuals. The average age is 50 years. The radiographic appearance is that of a circular radiolucency surrounded by a radiograph border and occurring in an edentulous area. Keratocystic odontogenic tumor is like keratocyst, keratinized epithelial lining, and extremely high rate of recurrence. It occurs over a wide range of age, from 5 to 85 years. The peak incidence being the second and the third decades. On the radiograph, KCRT may assume the appearance of any odontogenic cyst, primordial dentral, radicular, lateral periodontal, and residual cyst. It may produce cortical expansion of bone. The most common site of occurrence is the mandibular third, molar, and ramus areas. The lesion appears as an unicular or multicular radiolucency with a thin radiograph border of reactive bone. Odontogenic keratocyst shows striking tendency to recur after enucleation. And odontogenic keratocysts must be differentiated microscopically and radiography from other cysts and students. Basal cell Nevius syndrome, and its names also Wernicke syndrome. The occurrence of multiply keratocysts is a characteristic finding in basal cell Nevius syndrome. The syndrome consists of a number of abnormalities, including multiply basal cell nevi, multiply jaw cysts, bifid ribs, and intracranial calcification. The nevoid basal cell carcinomas are usually multiply and involve the face, neck, back, and thorax, often in areas not exposed to sun. Other anomalies have also been reported. Classification of pulse therapy, mild mandibular prognatism, ocular hypercolorism, eyes widely separated, piece on the palms and soles, characteristic frontal and temporoparietal palsy, and various skeletal anomalies. Basal cell Nevius syndrome appears early in life, between the ages of 5 and 30 years. And here is probably keratodontogenic cyst. You can see the expansion of the bone to the ramus, but only histopathologic results can confirm is it this tumor. You can see the big one. Big cyst, probably the tumor. And here you can see big degeneration of the ramus, of jaw, and the body. It's a thin layer of the bone only, so it is a dangerous to broke bone in this case. Calcifying odontogenic cyst is a rare, slow-growing, benign tumor-like cyst that occupies a position between a cyst and an odontogenic tumor, since it has some characteristics of a solid neoplasm, continued growth, and some features of the cyst. Equally distributed in the maxilla on the mandible, most of the calcified odontogenic cysts are found anterior to the first mandibular molar. On a radiograph, the calcifying odontogenic cyst assumes the appearance of any odontogenic cyst. The radial lucency may be ionicular or multiocular, and it is not unusual to find this cyst as a peripheral radial lucency to an enwrapped cyst. Initially, the calcified material may be visible microscopically only, in which case it is completely radiolucent. In other cases, the calcified component may be large enough to occupy the whole lesion. Treatment: enucleation surgical technique is enucleation, part 2, marsupialization, part 1, enucleation after marsupialization, and enucleation with curettage. Enucleation, extirpatio cysticectomia, part 2. Indications: treatment of choice for removal of cysts of the jaw, and should be used with any cysts of the jaw that can be safely removed without unduly sacrificing adjacent structure. Advantages: pathological examination of the entire cyst can be undertaken. In the initial excisionary biopsy is also appropriate to treat the lesion, and the patient does not have to care for a master marsupial cavity with consistent irrigation. Disadvantages: if any of the conditions outlined under the section on indication for marsupialization exists, enucleation may be disadvantageous. Enucleations involve complete removal of the cyst as such and sealing of the wound by primary intention. It's the most satisfactory method of treatment of cysts, and it is indicated in all cases where cysts are involved. Wall may be removed without damaging adjacent teeth and other anatomic structures. After taking a radiograph to determine the exact localization and size of the lesion, trapezoidal flap created, whose extent must ensure adequate access and visualization of the surgical field. Removal of bone and exposure of part of the cyst. Enucleation of the cystic cell. A curette is used for enucleation of small cysts, while for larger cysts, the broad end of a periosteal elevated is preferred, which is placed inside the cavity, passing gently between the cystic wall and bone, while the cyst is carefully grafted with forceps. After removal of the cyst, a curette is used to inspect the cavity for the presence of remnants of the cyst. And during the blood. Marsupialization is part 1. This method is usually employed for the removal of large cysts and entails opening a surgical window at an appropriate site above the lesion. In order to create the surgical window, initially a circular incision is made, which includes the mucoperiosteum, the underlying perforated bone, and the respective wall of the cystic cell. The contents of the cyst are evacuated and interrupt sutures are placed around the periphery of the cyst, securing the mucoperiosteum and the cystic wall together. The cystic cavity is irrigated with saline solution and packed with iodophore gauze, which is removed a week later together with the sutures. During the period, the wound margins will have healed, establishing permanent communications. Irrigation of the cystic cavity is performed several times daily, keeping it clean of the food debris and preventing a potential infection. Feeding the wound is by secondary intention, and the epithelium of the tooth is performed oral into oral mucosa. Maxillization indication. The following factors should be considered before deciding whether a tooth should be removed by maxillization. 1. Amount of tissue injury. Proximity of a tooth to vital structures can mean unnecessary sacrifice of tissue if enucleation is used. 2. Surgical access. If access to all portions of the tooth is difficult, portion of the cystic wall may be left behind, which could result in recurrence. Assistance in eruption of teeth. If an erupted tooth is needed in the dental arch, is involved with the tooth. For example, dentino's tooth maxillization may allow its continued eruption into the oral cavity. And extent of surgery. In an unhealthy and debilitated patient, maxillization is a reasonable alternative to enucleation because it is simple and may be less stressful for the patient. Size of tooth. In very large teeth, a risk of the jaw fracture during enucleation is possible. It may be better to maxillize the tooth and defer enucleation until after considerable bone heal has occurred. Advantages: a simple procedure to perform, and disadvantages: pathologic tissue is left in situ. Without root histologic examination, the patient is inconvenienced in several respects. This cavity must be kept clean to prevent infection, and because of the cavity frequently traps food debris, the patient must irrigate the cavity several times every day with a syringe. This may continue for several months. The cavity is enucleations after maxillization. Indications for this combined modality of surgical therapy are the same as those listed for technique of maxillization. If the tooth is not totally obliterated after maxillization, a cystic cavity or previously maxillized tooth is difficult to pierce. Enucleation after maxillization. Advantages: the same of those listed for maxillization and enucleations. In the maxillization phase, a simple procedure that spares adjacent vital structures. In the enucleation phase, the entire lesion becomes available for histologic examinations, and the development of a cystic lining, which makes secondary enucleation an easier process. And disadvantages: the same are those for maxillization. The status is not removed initially for pathologic examination. After enucleations, red group is used to remove 1 to 2 millimeters of bone around the entire periphery of the cystic cavity. This is done to remove any remaining epithelial cells that may be present in the periphery of the cystic wall or bone cavity. These cells could proliferate into a recurrence cyst. Okay. 1 second. A moment of break. Okay, I have the next presentation for you. Now we talk about odontogenic tumors. We had a lot of odontogenic tumors. I'm sorry, but sometimes it all wrong. A classification of odontogenic tumors according to the behavior of the lesions. Benign, we have epithelial, mesenchymal, or mixed. And epithelial, myeloblastoma, and adenomatoid odontogenic tumor, calcifying epithelium odontogenic tumor, and squamous odontogenic tumor, mesenchymal, odontogenic fibroma, odontogenic myxoma, and cementoblastoma, and mixed ameloblastoma, fibroma, and odontomas. Malignant epithelium, malignant ameloblastoma, odontogenic carcinoma, mesenchymal odontogenic fibrosarcoma, and mixed amelofibrosarcoma. Epidemiology of odontogenic tumor, odontomas 50%, ameloblastoma 15%, myxoma fibroma 10%, and others less percent. Important causes of swelling of the jaws, cysts, especially odontogenic ones. Odontogenic tumors, most common neoplasm, GM cell lesions, fibrous cell lesions, and primary non-odontogenic neoplasm of bone, metastatic neoplasm, and chronic osteomyelitis. Radiology of benign tumors, well defined, sophisticated, space occupying, displacement of teeth, displacement of anatomical structures, directional resorption of teeth, and radiology of benign tumors, we have well defined and clearly defined, sophisticated, space occupying or non-space occupying, space occupying, myeloblastoma 15%. This is the most common neoplasm of the jaw. Clinical features, age between 4 to 5 decades. No sex predilections, mandible more than maxilla, 80% of cases were in mandible. In the mandible, 70% of cases were in molar region. Factors, asymptomatic, slowly growing, discovered by X-ray, radiographic appearances, and multilocular radiolucent area, honeycomb pattern, and expanded lingually. Unilocular radiolucent area usually associated with impacted tooth, and in dangerous waste. Typical presentations of ameloblastoma. You can see on the pictures, there is a rounded bony swelling of the posterior alveolar bone, body and angle of the mandible. There is no ulcerations. A feature only seen in very rare tumors, which have perforated the cortex. The typical radiological appearance of ameloblastoma is a multilocular cyst or multiple cyst cavities of different size, as shown here. Solid or multicystic ameloblastoma histologic features. There are several microscopic subtypes, but these generally have little bearing on the behavior of the tumor. The follicular and plexiform types are most common. The follicular type is composed of islands of epithelium which resemble the enamel organ in a major fibrous connective tissue stomach. Solid or multicystic ameloblastoma. The plexiform type is composed of long anastomotic folds or larger sheets of odontogenic epithelium. Its stroma tends to be loose and more vascular. The acanthomatous type shows evidence of extensive pronounced metaplasia with keratin formations in the island of odontogenic epithelium. In the granular cell type, there is transformation of groups of epithelial cells to granular cells. The nature of the granular change is unknown. The type is more common in young patients and has been shown to be clinically aggressive. The desmoplastic form is composed of islands of odontogenic epithelium in a very dense collagenous stroma. It has a predilection for the anterior maxilla, and because of the dense connective tissue, may appear as radiolucent radiocoherence. The basaloid type is the least common and is composed of uniform basaloid cells with no stellate vertical. You can see on the picture ameloblastoma. In some studies, solid multicystic ameloblastomas are reported to be more common in blacks. While lesions are generally asymptomatic, ameloblastomas may cause paresthesia, pain, particularly if infected, and they can erode the cortical plates. Treatments have ranged from simple enucleation and curettage to end-group resection. Marginal resection is the most widely used method of treatment with the least recurrences reported, up to 15%. And most surgeons advocate a margin of at least 1 centimeter beyond the radiographic limits of the tumor, as the tumor often extends beyond the apparent radiographic clinical margins. Treatment with curettage has resulted in recurrence rates ranging from 55 to 90%. Treatment with marginal resection has resulted in approximately a 15% recurrence rate. Ameloblastomas of this type arising in the maxilla are particularly dangerous, as it is often difficult in getting adequate margins. Rarely is an ameloblastoma life-threatening. You can see on the picture. Unicystic ameloblastoma. Patient age. Patients are younger than those with the solid or multicystic form. 50% are diagnosis during the second decade of the life. Allocation, 90% occur in the mandible, usually in the posterior region. Radiographic typically appears as Around the crown of an enwrapped tooth, most commonly a mandibular first molar. Which histopathologic variants are recognized? Luminal, the tumor is confined into the luminal surface of the cyst. Intraluminal plexiform, the tumor projects from the cystic lining, sometimes resembles the plexiform type of solid multicystic ameloblastoma. And mural, the tumor infiltrates the fibrous cystic wall. Unicystic ameloblastoma, you can see luminal, unicystic, intraluminal, mural, and solid multicystic. Enucleation of the cyst is probably adequate for the luminal or intraluminal plexiform types. Treatment of the mural type is controversial with some centers, believing the local resection is best. 10 to 20% recurrence after enucleation and curettage with all unicystic ameloblastomas. Peripheral ameloblastoma. These tumors are extraosseous and therefore occupy the lamina propria underneath the surface epithelium but outside of the bone. Histologically, these lesions have the same features as the intraosseous form of the tumor. Wide age range, but most occur during middle age. Location posterior gingival alveolar mucosa is involved most frequently. There is a slight predilection for the mandible. The buccal mucosa has been the site in a few reported cases. Although not in bone, a few cases have found superficial erosion of the alveolar bone. Islands, histologic islands of the ameloblastic epithelium are observed in the lamina propria. Plexiform and follicular patterns are the most common. In 50% of the cases, the tumors connect with the basal cell layer of the surface epithelium. Unlike its intraosseous counterparts, this tumor has innocuous clinical behavior. Patients respond well to local surgical excision. Some reports indicate a 25 recurrence rate, but in these cases, a second surgical procedure results in few. There has been a rare malignant change reported. Adenomatoid odontogenic tumor is a benign epithelial odontogenic tumor characterized by tooth-like structure variable degrees of inductive change. It is probably a hamartoma. Clinically, age, second decade of life, young adult, female more than male, maxilla more than mandible 2 to 1, most common in canine region. Slowly growing, painless discovered by chance on X-ray, both jaw expansion, especially of upper canine region, usually related to aneurysm tooth, may resemble dentigerous tooth both physically and radiographically. The radiographic picture, well-defined radiolucence area related to aneurysm tooth, and inside this radiolucences, cataract radiopathology may be seen. You can see on the picture adenomatoid odontogenic tumor. Microscopic picture, size few centimeters capsulated. Pure surface is grayish white in followed with dark areas of camouflage. It may show one or more cystic spaces. A tooth may be embedded in it. Histopathology, microscopic picture, this tumor is capsulated. The tumor is composed of sheets of small or spindle-shaped epithelial cells with weaved speculum and oval nuclei. These sheets of masses are arranged in whorly patterns. Some of these cells will differentiate into tall columnar cells resembling ameloblastic and arranged in different patterns as follows. Tubular structure, the rows of cells with eosinophilic homogeneous material in between to the root. Convoluted bands, two rows of cells with eosinophilic material in between the two rows with the shape convoluted tubules. And duct-like structure, some of tubular structure may expand open to include a central space surrounded by single layer of flat columnar cells. And the nuclei of the radially arranged tall columnar cells are situated at the basal cell of the cell. The central space contains a homogeneous eosinophilic material forming a thin layer in contact with the free end of the cells. This eosinophilic material is thought to be a basement membrane-like material since it passes quickly. The tumor contains very small amount of cytostoma which may undergo degeneration to give a tripliform pattern under microscope. A small foci of classification of hyaline material may be presented, which was described as dysplastic abnormally formed dentin. Cytogenesis of adenomatoid odontogenic tumor, enamel outcome is determinant. Treatment, this tumor is capsulated, so it is treated with simple enucleations. Prognosis, good prognosis in the tumors is benign with no rate of recurrence as is it capsulated. Calcifying epithelial odontogenic tumor, Gilbert tumor. It is a benign but locally invasive epithelial neoplasm characterized by the development of intraepithelial amyloid-like material which may become calcified and liberated into surrounding stroma. Relatively rare neoplasm as compared to AB, but it could be mistaken of a purely differentiated carcinoma. Clinical picture, age average is 40 years. Greenberg discovered the male and female occurrence in equal incidence. Mandible more often than maxilla, 2 to 1. In mandible, the most common sites are molar and premolar region. All the cases are associated with the crown of an eruption. Tartars, slowly growing, symptomless heart due to calcifications. Diffuse or well-defined swelling, and usually a missing tooth is observed at the site of the tumor. You can see calcifying epithelial odontogenic tumor. Radiographic irregular radiolucence area with radiopapuria of variable size, usually related to the crown of unwrapped tooth. The peripheral zone of these lesions is radiolucence, which may or not may be well demarcated from the normal bone. Usually, radio opacities increase within the tumors as it matures. Histopathology, tumor is made up of sheets of polyhedral epithelial cells with well-defined borders and prominent intercellular bridge may show cellular pleomorphism. Rounded and eosinophilic homogeneous masses are often present in the epithelial masses. These masses are commonly calcified in concentric way to form what is called light ganglings. Epithelial cells may degenerate to liberate all the calcific basophilic rings into the surrounding stroma. Fusion between calcific rings occurs to form large irregular masses. The eosinophilic pink material gives the similar staining reaction of amyloid. Origin of this amyloid material may be due to active secretion of these cells, a product of polyhedral cell degenerations, genesis, most probably from reduced enamel epithelium of impacted and unerupted tooth. Pivotage will result in recurrence, not calculated. Complete resection of the tumor viewing area of the jaw will result in complete and permanent cure with good prognosis. And causes of aggressiveness of this neoplasm, irregular flow of neoplasm towards the surrounding bone, and lack of encapsulation. The tumor is not capsulated. The most odontogenic tumor, it is an intrabony, central benign but locally invasive neoplasm arising from island of well-differentiated squamous epithelium presence in fibrous stroma. This neoplasm was considered as a variant of simple AB. Clinical picture, few cases were discovered around age 5 decade. The tumor is multi-centric in many bones. Most cases follow a benign course, for example, slowly growing painless. In other cases, the tumor may be rapidly growing, cause bone destruction, and cause surface alterations. Radiographic picture, uniocular radius area, island of the well-differentiated squamous epithelium found in collagenous stroma resembles follicular AB. In contrast to simple AB, are surrounded by a layer of the flat low-glowing cells. Epithelial island may undergo calcification. Melanotic neuroectodermal tumor in infancy. Definition: it is a rare neoplasm or hematoma of unknown nature is confined to infants less than 1 year old. Clinical features: infants less than 1 year, 6 months. Female more than male. Maxilla more than mandible. Character: pigmented or non-pigmented swelling of the gums may be central, for example, intrabony. Initial rate of the growth is rapid. Resemble malignancy, then the rate becomes low after some time, then it may stop when the tumor reaches a certain size. Radiographic picture: peripheral lesion outside bone is negative in X-ray except when causing bone erosion. Central lesion is weight reluctance area, usually multilocular with displacement of neighboring teeth. Lesion is not capsulated. Two types of cells are found: epithelium-like cells arranged in strands of sheets of duct-like structure. Lymphocyte-like cells that is tended may be small cells with dense rounded nucleus or may be larger with larger nucleus showing fine chromatin. Lymphocyte-like cells may be found inside duct-like structure of epithelial-like cells. Sometimes other type of cells is also present. We can find small collection of polyhedral of delayed self-phase with fine melanin granules. The lesion is not capsulated and the margins of the tumor is irregular, giving innovative appearance of delta lesion. These type of cells are found in well-formed CT stroma, which is sometimes fibrillated. Enameloma. Enamel pearl, this is developmental malformation in which small nodule of enamel develop on the reticular portion of a tooth, usually upper molars, at or near the root bifurcations. Microscopically, it is a small circumscribed nodule of normal enamel. It may be normal prismatic structure or normal enamel with a core of dentin and pulpy tissue. Histogenesis, it develops as a result of disturbed development of an area of epithelial root set of hair-free differentiated into enamel order line down enamel. Odontogenic fibroma, benign fibroblastic neoplasm with presence of epithelial rest. Odontogenic origin, it is rare endostic tumor. Age first decade. First 2 decades of life may be discovered later. Mandibular molars and premolars, painless, slowly growing, well circumscribed, post-slight jaw expansion, usually arise new root of tooth or in place of missing tooth. Dark defined right junction area in a tooth bearing region. Odontogenic myxoma, benign, but locally inverted neoplasm consisted of stellate cells of mucoid stroma, resemble developing dead dental papilla. Young adults, mandibular more than maxilla, usually painless, rapidly growing due to accumulation of mucoid material, fusiform swelling, post-jaw expansion, usually covered by only thin layer of bone and usually related to place of missing tooth. Multilocular radiolution area, so bubble radiolucency with impacted tooth. Treatment of odontogenic fibroma is complete removal by simple enucleation, and myxoma, you have to complete removal with safety margin as locally inverted. Myxofibroma, you can see on the picture. And also there. Cementoblastoma. It is the only neoplasm of cementum. It is a benign one. Age, young adults, male more than female. Mandibular first molar region. Slowly growing, painless, vital tooth, X-ray radiopact mass with a radiolucentorium attached to the root apex. Resorption of the related root is common, vital tooth. Histopathology, mass of cementum with many reversal lines. Cellular CT with cells resemble osteoblast and asteroclast. May be mistaken as osteosarcoma. Peripherally, a band zone of unmineralized tissue surrounding the capsule. Excision with tooth extraction with a good prognosis. Cementoblastoma, you can see on the picture. Cementoblastoma. Malignant mesenchymal odontogenic tumors. Odontogenic fibrosarcoma. This is a rare neoplasm which results from malignant transformation of odontogenic fibroma. It resembles odontogenic in mature CT fibroma, but the cells show histological and cytological criteria of malignancy. Treatment is by complete excision with safety margin. Mixed odontogenic tumors, benign. Ameloblastic fibroma. It is a mixed odontogenic tumor composed of actively proliferating neoplastic odontogenic epithelium found in cellular actively proliferating neoplastic fibrous tissue similar to follicle or dental papilla of the developing tooth. Clinical features: age below 21 years, 6 male to female, more than female. Mainly mandibular premolar and molar area. Rare, painless, slowly growing, produce jaw expansion and does not invade into the surrounding disc bone. You can see. Well-defined uniocular or multilocular radiolucens area, sometimes with impacted tooth. Cytopathology: the epithelial elements forms polypus similar to ameloblastoma. Peripheral layers of cuboidal or columnar cells and central mass of stellate cells. The follicles of epithelium form several shapes: compressed follicles, small nests, and rosettes. The CT is much more cellular than CT ameloblastoma, and the cells are fusiform or angular with primitive fibrous tissue, resembles immature dentin papilla. Sometimes a layer of juxtaepithelial granulation is found around the epithelial alveoli, and treatment excision with safety margin. Ameloblastic fibroodontom. This tumor resembles ameloblastic fibroma but with inductive changes leading to formation of enamel and dentin. It is difficult to differentiate the lesion from the early stage of composite odontom. Multilocular, well-defined radiolucens area with radiopaque masses. Histology: similar to odontogenic myxoma, but with odontogenic epithelium showing active ectomesenchymal border. The layer just around the epithelium is called cell-rich zone, and formation of enamel and dentine. Odontoms: compound odontom, developmental malformation, hamartoma consists of a large number of denticles in which enamel, dentin, cementum are arranged in normal fashion. Age: children and young adults, more female than male, anterior maxilla and mandibular molar area. Lesion is usually small, asymptomatic, causing expansion, diagnosed by routine X-ray, and it is associated with permanent dentition, but may be associated with deciduous teeth. Multiply odontoms could be present, and radiopaque numerals look like structures arranged in various fashion. And today I exposed you compound odontom, compounds from five odontomas, and it was at 22 years man, and he had deciduous teeth number 6-3, impacted teeth 2-3, and compound odontom between dent 2 and 6-3, and I extracted the teeth 6,3 this compound odontome and uncover the T23 with cleaning the attachment to orthodontic growth, and then orthodontic will be do with this tip. And complex odontome developmental malformation and hamartoma in which the enamel dentine and cementum are arranged in haphazard fashion. More often in mandibular molar area, is usually small, asymptomatic, causing no ion. Small lesions are diagnosed by X-ray. Some cases developing in association with a place of missing tooth. And enucleation is okay, but complex odontome removal with conservative surgery. Odontomas, you have complex odontomas, mixed. So there, and here compound odontoma. Oh yes, and this compound odontoma, and something like this today and expropriatio. Okay, I think it's all of the last lesson today. We can finish maybe next week, but we have also presentation. We have also a lot of presentations for the next week. Wait a moment, I will do a print screen for your list. Okay, thank you for this lesson. See you next week. Bye bye.